We are here to celebrate International Day of Persons with Disability. And the theme for this year is Inclusive Societies for Advancing Social Progress. And when I came across this, and also, nowadays you kind of have a lot of access to podcasts where you're listening to parent voices. I kind of started wondering what is our role as therapists? Because most of the time you hear NGOs or special educators, social workers, those sort of professions talking more about inclusion and very much based into education or educational, level. So what do we as therapists sort of think of inclusion, or what is our role in this journey of inclusion, right? So that's why we thought, let's just have this little conversation and, have a discussion about what we can do, what we are doing, and so I first want to thank all these panelists who with one phone call agreed to join in this crazy discussion with me. So let's begin because I would like to have the audience sort of engage with us as well. So let's begin. We kind of, when we were discussing the panel, when we were discussing how to structure this hour, we kind of realized that the concept of inclusion is so vast that you really cannot cover it in one small panel discussion. But we thought we'd like to focus on two or three main sort of points. And we kind of looked at, if you look at how sort of our societies and families are structured. So that's the kind of flow we would like to go through. um, so having said all that, let me sort of begin with my first question. Like I said, we usually hear the word inclusion or advocacy for inclusion at a later stage, in the child's life where they are maybe trying to get into a school setup or in a more of social or participatory kind of activities, right? But we start therapists, right? We start working with these families at a much earlier stage. So when do you all think inclusion begins? How does inclusion begin? And then my follow-up would be, what does one do as a therapist to start those kind of conversations or, thought processes, or how do we support this journey so that when this parent or family is at a later stage, they are already a couple of steps ahead of the game. So I'd like to start with Dr. Ashish, if you can share your thoughts.
Uh, Good evening, everyone. Uh, the discussion that you have started today, I think, it should have our thoughts, and everybody should contribute to this very idea and very concept of inclusion. Inclusion is actually, it's like the definition of handicap. It is the person who have got everything, in life, can do everything, can participate in the society. But when these people, they don't accept a person or a child with disability, in spite of having the ability to go to mainstream school, or, a person can get a job. So it is the person, it is the population which do not, who are neurotypical, quote unquote, when they don't accept the person with disabilities even with, with all his abilities or special abilities or with special assistive devices. So that is a condition, and it's a kind of more of mentally include that, that person is with us, a part of us. It is not that, we are giving them some facilities or, so that the person can be included. It's a kind, the person is there as a whole, in the whole community, in the whole society. So that is the concept we should inculcate in our society, and especially in Indian context. I would like to say that, in our mainstream educational institutions, right from the Anganwadi centers, where I have seen, the disinclusion starts, people from of a particular strata, they go to those kind of schools, and there are other more socioeconomically advanced part of the society, they go to another school, they get a different kind of education from different institutions. So I think, our job is to include us in a society where we are all equal. That's the kind of concept, I would like to promote here.
Anima, would you like to share your thoughts?
Absolutely. Very well said, sir. I absolutely concur your thoughts. For me, inclusion, as I see it, basically, having been a pediatric therapist for such a long time, I see that inclusion, begins right when the child is diagnosed and leaves the clinic or the hospital setup and enters home. Inclusion does not begin with any admission forms. It begins with the first assumption that we make about the child. So be it presuming competence when it comes to child's abilities, be it providing communication access, be it setting expectations of parents, all of those include or involve inclusion. Involving the child in making basic decision making is also inclusion, which as a parent, even as having typically developing children, we always make certain decisions for them in their younger age. That's also not inclusion. We think it's our right to make those decisions, and let alone these kids who have a label or a diagnosis, we don't let them do that. So involving them at those smaller levels, smaller decisions, do you want Cheetos or you want a chips, even those decisions are also a part of inclusion. And that's how we carry forward the movement of inclusive education or inclusive therapy.
Great. Ushma?
Yeah, thank you, Anima. Thank you, sir. Both of you had very valid points. And I would just like to add that, for me, obviously supporting inclusion as a rehab professional is an ongoing journey. And yes, it's a difficult one even to have conversations with parents to start with. Okay. Let alone the outside world first. But for parents also to start with, the conversations about inclusions, for me, I start right at the first initial evaluation or consultation or first meeting with the parents. And how do I do that is, as I go through my evaluation, I find out and I start having, conversations with parents as to what is the family routine, what is the mobility level of the child, so that the child, how does the child move within the home environment and in the immediate environment outside the home, meaning be it in the society compound or a neighborhood park or even in the lobby of, outside their apartment. Or how does the child, does the child sit at the table along with the family for meals? Then again, in every, in the in the mobility and in the feeding, the 2 points that I would bring up. And then there are many other points. But even let's say, if we say feeding, is the child self-feeding or is the child just being fed? So, inclusion is very vast. And as Pooja said, 1 hour is just not enough. It's a very small, we are just going to scratch the surface. But basically, I try to understand, many aspects of the child's life in terms of, sitting, mobility, feeding, playtime with siblings. How does the child interact with whoever walks into the home, like our domestic helpers? Is the child expressing their needs? either verbally or through gestures, is the child expressing their needs? And, hereby combining all these points, the child should feel why. I explained to the parents, the child should feel understood and the child should feel valued, right, starting from home, because everything begins from home. And I think we are the first professionals, rehab professionals are the first one, PTOT or speech. We are the first point of contact after all the medical diagnosis and the medical testing and hospitals and everything has been done. So we are the first ones, the first point of contact, and we have to start the conversation, right? I do it during initial evaluation, but it can be done as early as possible, right, within the first few sessions when we start seeing the child.
Yeah, fair point. I think all of you had, great sort of views on this topic. Coming from the NICU, I have a slightly sort of like a precursor to all of this, right? A lot of the therapists that I talk to they get a referral. So they've gone through that process, like Ushma said, they've gone through the testing, they've gone through the assessments, or they've gone to a doctor saying that, okay, now I admit my child is way far behind, I need help. For me, from the from my experience in the NICU, um, there is just so much that is alien to this concept of, giving birth to a child, right? Like there is this rosy picture in your mind, you kind of hear, or, you're bombarded with so many of these positive pregnancy and, pink, healthy, chubby baby images, that it's quite a shock for the parents to, have this preterm birth. And I feel like um, a lot of times that in itself alienates them from the general, like if my friend has had a baby or is going to have a baby, but they don't experience a NICU stay, they are already excluded, and so when we are talking about inclusion, I feel like, that it could start. Again, this is an ICU sort of experience, but we've had on the parent support group so many mothers say that, we have been worried for a while. We don't know who to talk to. If you ask the women in the house, they kind of say, well, my child did this at this age, my child did it at another age. We don't know who to kind of believe. The grandparents don't want us to worry, or, the doctors kind of don't give a referral to a therapist. Or a lot of times the doctor, like the mother doesn't even know that a therapist exists, right? The doctor will say, go to a therapist if there is a concern. So the approach is to a pediatrician, and if, it's basically their judgment on that given day. So we don't have parent access to screening. We don't have those kind of systems in place. And so I feel like, that demarcation starts quite early, like even before they step into our clinics, isn't it? And so some part of it we, obviously will address a little later when we talk about advocacy and our role in those kind of, sort of processes. But as a therapist, I feel like I need to be very aware of the journey, the difficult journey that this family is going through. And that kind of, what do you say? Like, I need to be kind, a lot of times we are like, okay, do this, do that, and they are just struggling because the terms are new, the experiences are new. I feel like forget all of this, forget all the atypical, but even the typically developing children, sometimes I feel like parents nowadays don't know what to do with their, babies. They don't know how to like use language and communicate. A lot of the times we'll say, talk to your baby, and the mother will be like, oh, okay. And then she'll just do, those kind of noises instead of actually using sentences. And so I feel like, we need to have, first of all, that understanding of what they're going through, because I don't think like that power hierarchy helps anybody, right? Um, and one other thing I want to say, and I think actually Sir had said that in one of our conversations, which really, stayed in my mind, is that if you look at a typically developing child, you're not saying, oh, today is a motor skill day, or today is a speech day, or today is an OT day, or today is a fine motor day, right? So we don't really look at development in in those boxes. And we kind of tend to do that when they move into a therapy, process. And so, sir, I don't know if you'd like to actually, like I said, I know you had said this and explained it so well. Maybe you can jump in here.
Okay, okay. I think, I would like to say that, we need to promote intervention through integrated ecosystem, not as competing silos. So, what happens is we, the five different therapists with our own knowledge boundaries, we sit in different silos, and the family and the child comes to us, moving from one room to the another room to the other room. So in the process, what is missing out is nobody knows the child
Mm.
fully. As we look, if we look at typically developing children, they don't develop speech first or walking first, or communication first, or nonverbal or verbal communication or social communication. There are no domains. We have separated the child, compartmentalized the child in separate domains. So what is happening, this is basically a Western concept that we have taken from them, that, we need to have separate professionals for the child. Maybe, in their infrastructure, it is possible because they have less number of children, more professionals, qualified professionals. But in India, in my country, the scenario is totally different. We have a very few quote unquote the qualified professionals who can really deal with the children with special needs. So what happens is, what my feeling is that we need to sit together, we need to share our knowledge in order to give them a program which is comprehensive, which is doable for the parents. So it is like, five different professionals sit together, look at the child's problem, and give the parents, at least two activities which is doable for them to do at home. That is my message, and I would like to say that, we should also prioritize the purpose of interventions. What are we trying to do? I mean, we should have the prioritize of prioritize the purpose of intervention over rigid protocols. Often we say that no, you will have to put the ankle foot orthosis throughout the night. See what happens in India. It's a hot country, and the child cannot sleep whole night, and the mother sleeping beside the child cannot sleep whole night. So the entire family system breaks down. So, I think, we need to sit together, and this is the high time to think that, how we can provide the comprehensive program to the family, which they can do it at home.
If I,
Right. Go ahead.
sorry, you wanted to go ahead, Ushma?
No, go ahead, Anima, go ahead.
As Pooja said, no, she sees the kids at a different age group, and I see at a different, and we all see at different ages. So inclusion is a dialogue that is, it's non-linear, it is continuous, and we have to have it at different stages of life because it looks so different.
Yeah.
So for me, what I usually do is, without lowering the expectations of the parents, the first thing as therapists we need to address is the grief. Because as Sir said, it changes the entire family dynamics. It changes the team, and which itself is such a, having a child with a known deficit or known disability is such a difficult situation. Plus, the entire family goes for a toss. So addressing that grief also is a part of us as a therapist. And if we don't address that grief, we're truly not addressing the inclusion. The next thing that what I do is try to reframe at again different stages in the child's life. Try to reframe the concept of normality
Yeah.
to participation. At each stage it looks different. I'm pretty sure at Puja, at a NICU level, if you start talking, having these dialogues to parents that, let's talk about participation, they will not be
Yep.
accepting those dialogues as well. Once a child is little bit, older and going to, preschool or toddlerhood or, school, that's when the parents start realizing that my child needs to participate more. Let me not look at normality anymore. And then I am a person, I work with adolescents and kids 10 and above, and for me inclusion at that level and the conversation at that level looks absolutely different.
Yep.
So
Correct.
from as therapists we always start with a child centric approach, but actually we have to move towards a life centric approach. And that's where Sir said that all of us need to together be included ourselves to be, helpful for the child. From a milestone centric approach to a participation centric approach. That's how as therapists we need to move and start visualizing the client in front of us.
Absolutely.
Yeah.
Ushma, you had something to say?
Yes, yes. Very valid points by Sir and Anima. So very valid that you move towards a participation approach. And moreover, you move from not move necessarily, but along with the child-centric approach, you also have a family-centered approach. What is the family going through? So as Pooja said, first of all, they're going through the grief and their emotional situation, which does last a long time in many families, beyond toddlerhood or sometimes towards preschool age. It's not that one fine day the parents are going to really accept it. It is a long journey for them, a very hard journey for them. So then when you do your initial evaluation or even during your early sessions also, right from the start, we need to reframe our language. Rather than saying, oh, a child can not do this, not do this, not do this. So hence the child has to do these exercises or these things. Hips are weak or the lower back is weak and therefore your child cannot sit. We have to move away from their language. That language, we have to talk in a positive language. Okay, let's see what the child is able to do. Let's see in this sitting or standing, what else the child is able to do. So as Sir said that we need to move a comprehensive approach. I absolutely agree with it. I practice it. So when I say comprehensive approach, in the sense that if I'm working, if I want a child to work in sitting or standing, I also include toys that are fun, that also address, touch, they address some visual skills, visual abilities, etc. Now, I'm not taking work away from the OT or I'm not replacing an OT. However, I'm providing fun to the child, something that is fun, something that they enjoy, something that they're able to do, something that gives them success, along with the sitting, standing, otherwise the sitting, standing becomes punitive for the child. Oh, I'm in therapy and I have to sit or I have to stand and do this or I have to maintain balance, So there is the need to introduce these things. We are not taking, we are not replacing the OT. But at the same time, that is a reality that our country differs, in urban and rural areas. Even in the same urban areas, we come across different populations from different economic classes. And not everybody can afford to go to a PT, OT, speech, all of the professionals during a certain time period. So then in that case, everybody has to be aware of the other domains, for example. And when Sir said that, okay, that's a Western model, Sir, I would disagree a little bit here, that only in India we practice, early intervention. If we talk about 0 to 3 years, that is early intervention by definition. Only India we practice that, children that is 0 to 3 years are referred to separate professionals like PT, OT, speech, etc. The Western model in the United States, I worked in early intervention, and there only one therapist, either it's the OT or the PT or the speech, whoever is available as per their schedule or the accessibility to the home, because since more than 2 decades or almost more than 25 years, the US early intervention model has moved to the home of the child, meaning because they believe that the child best performs in the natural environment, which is our home. So the EI therapist, who can either be an OT or PT or a speech, goes to the child's house. And again, not daily as people expect here. They go maybe once or twice or thrice, depending on the need and the potential, or there are many more points to consider about that. They come up with what the frequency would be. But there, the 0 to 3 years model, the EI model, can be practiced by any one of these three, and all three do everything. Like if it's a physio, they also educate the parents in fine motor and other sensory stuff, and communication stuff, or vice versa. If the OT is also doing the same thing, same or similar thing, let's say. Basically, whoever the EI therapist is going home will be touching on all the domains and then educating the parent. It's just not doing therapy, doing something for the child and leaving them there in the house. It is getting the parent absolutely involved in the therapy, in the play, in the fun, in that therapy time, and educating the parent. Why are we doing this? What needs to be done? How will your child benefit? We are constantly educating the parents towards a wholesome development or a holistic development. So this is where, what I would like to say, that yes, therapy has to be comprehensive. We cannot compartmentalize. And then the stuff that we have learned, the different domains, they have come from a need for a need for professionals to understand the theory behind it. But then that theoretical understanding has to be taken to the ground level, and very difficult to do in in physiotherapy, occupational therapy, because we can't follow protocols. We just cannot follow protocols. It has to be a comprehensive therapy that looks more like fun. It has to be done through play, because these are children, no matter what the age they are. And it has to be done through certain functional tasks, because play, fun, function. So there I would like to bring the F words: the fun, the function, the fitness. So, we are all therapists, so we have to think about the fitness level of the child. What are we doing, and does it contribute to the fitness level of the child? Family. How is the child a part of the family? I already spoke earlier. Does the child have friends? Opportunities to make friends, through whatever their situation is. And then finally, putting all this together, we have to be a little cognizant about the child's near future and maybe a little few years down the road.
So, sorry.
Yeah, no, go ahead. Sorry.
No, I was just going to say that I have put up a little document in the chat window, which has a list of resources. Like Ushma said, when you are working in EI, the early intervention system in the US, you're forced to learn about the other domains, that are going on alongside, whatever your focus is. And so the first two resources on the list are what are called the help charts. They are, I was surprised actually, I'd never checked the price, but they are surprisingly cheap to purchase in India as well. And they are a very lovely way to look at all the domains. And even for the parent, it's a very visual, nice visual for the parent to kind of see where the child is falling. And the second resource is the ages and stages questionnaire. They have two sort of groups. One is where they have the 5 domains, and one is the social emotional one. Again, a lot of these are just freely available online, so you can just look up the age that you're, the age questionnaire that you want, and I'm sure you'll find it online. So I wanted to mention that we have those resources up there. And then from that, I will actually move on to the next sort of theme that we wanted to touch base upon today, which was the family, right? Ushma, you had a very nice segue into that, where if you look at all the evidence that is coming up, we see that the focus is more towards the function, or rather the structure and the body function part of it, but less on the fun, the family, fitness. Those kind of efforts, are friends, they are slightly less focused on in therapy realms. So one of the things that I feel, again, I don't see enough, but again, my perspective is a limited. because I work only in the NICU and the follow-up clinic. So I really don't see some of these older kids. But I don't see enough power wheelchairs or forget power wheelchairs, but like assistive devices, right? And when I talk to parents who have older children, most of them are still focused on independent walking at the expense of this child going to a school, right? Cognitively, they might be doing really well, but because they're not walking, they don't want to even attempt to discuss a schooling transition. And I feel the same with the communication devices. I feel like we're losing out on precious time by not advocating for early communication, because then we are struggling with managing behaviors that come from, the lack of language skills. So I would like to sort of, you know, open that Pandora's box and see where we land up. Yeah. So, Anima, would you like to, just take us through a journey of the communication devices?
Sure. Uh, I've I'd like to draw from what Dr. Ushma said about involving the family first. So, the child is an entire regulated nervous system, and the family comes at the crux of it. Only when the family is, sorted, the nervous system is regulated. So, first thing that I would like to, mention here is redefining the meaning of independence to families. So most families that I deal with, they think that not being able to do anything with the or everything with the body is dependence. But that's not how independence looks like. Independence is having a choice. Independence is having the control. It's having the agency. So when it comes to speech and communication, family feels that if a child is not able to use the speech equipment that we have for communicating, the child is dependent. And that's why there is always a fear of using these assistive devices. So to redefine that independence is that give your child a choice, give your child the dignity to participate. And once we are able to reframe those thoughts, the conversation of assistive tools will gradually flow into a child who uses ASC, who uses any other form of communication like visuals or gestures or even communication picture board. Or in that matter, if you say an adapted pen to communicate, all of these are not taking away the child's or making the child dependent. These are all providing the child independence, that it is all supporting the child's independence. So the conversation needs to be framed that way. And what I feel is the system, our education system as therapists also has not equipped us enough to have these kind of dialogues. We are ourselves learning, and I can speak on behalf of the speech pathologist community that although AAC and assistive tools are a major part of the curriculum, but do we really have had that exposure? We haven't had that exposure. We've had that exposure with picture based tools, which again gradually become very reiterative and do not serve a purpose beyond requesting something. So if I give you a picture of a bubble, you give me the bubbles. So beyond requesting, it gets very difficult to move beyond a picture-based tools. And as per if we look at the cognitive development of the child or the whole child development, we should always presume competence. Non-speaking or non-verbal does not mean non-thinking, right? So presume that competence and provide the child with a high-tech device. So that's where the direction in speech pathology is going, in assistive communication is going. So when I say high-tech devices, I mean iPads or 4-button devices where the child can press and convey a command or a label or a request, or even can I tell a joke and just laugh it out, ha ha ha, even though there is no joke. So just that social aspect where the child feels included in the class, or just a good morning, that is where it all begins. And all of these begins when we start reframing the thought of the parents towards that independence. What does independence look like for you as a family? And the answer to this question will be different for each family and for each child.
Very well said. Very well said. I think you're absolutely right. Um, First, like you said, it looks different for every family, and then we need to redefine, because when even when you started, with this kind of thought, to me, I was like, you're right. When I'm thinking of independence as a motor person, I am really saying, is anyone touching this person while they're performing something? If that is the case, only then will I label it independent. But you're right, we need to, change our perspective, change our thought. Sir, do you want to jump in?
Uh, my only thing is, we being the therapists, I think we should talk in the same language. I think that is something, which I feel is terribly missing here, because every professional talks in terms of, their domain. So when we, put the child in a particular posture, and when we allow the child to, touch his nose or eyes or hair or head, you know, that is the kind of message the parent should get, that this is the position where my child can play, and through play the child is learning so many things, the body parts. When the mother says, you touch my nose, the child is, every time the child hears the word nose. So that is how the development is. I mean, development is never like, okay, I will give you 2 years to walk and then I will teach you something. It never happens like this. So I think in the children who are not speaking, we need to tell the parents, and every professional should tell in the same language that, expressing is the main thing. Whether I am expressing myself through speech or expressing myself through showing a picture, or eye pointing or finger pointing. So that is how I think, the kind of integrated knowledge should be established, and the child should be treated in an integrated manner, and the family should see how we work and how we develop the child. So it's a kind of, naturally every mother will ask, every father will ask, they ask just two questions. From my experience, I am telling you, first thing they will ask you when my child will walk, and when the child will start walking, they will ask you when my child will talk. But walking and talking, beyond that, there are many things the child can learn. And I think, we need to bombard this into the parents' mind, that, this is how you can develop your child. Because what happens if you tell all these things to the family next time will visit another hospital. They will be in another group of, hands of another group of therapists, and they will be saying, no, 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 your child will talk. No, 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 your child will walk. So, it's a kind of, that is how I think, we need to integrate ourselves. We need to include ourselves, and the family should be in the center stage.
So to
Yeah.
add to your observations, it is very different when a child isn't walking. It's very concerning when a child isn't walking. But when a child isn't speaking, it is always wait and watch.
True.
Yeah.
Yeah. Can I jump
Ushma,
in,
you want
Pooja?
to add about assistive devices
Yeah.
as a motor therapist?
Yes. So what I face the difficulty, Anima, it's not only about AAC, it's just a little more difficult than a walker or a wheelchair, just a little more difficult. AAC is more difficult than that. Wheelchair, wheelchair or a walker with a child. And although this is only a pediatric topic, but I would say even for our senior citizens, these are really taboos I encounter in our society. Same as sir said, if I said, okay, I'll train your child with a walker, or we'll explore how we can use a walker, some other professionals will say, nahi, abhi to time hai chalne mein, baki hai. Your child will walk one day. When, as an experienced professional and my testing and everything, I have seen everything, but I'm not going to tell the parent. I'm not going to scare them at this moment, right? Or I'm not going to use negative words. But this is what I face, walker and these assistive devices are a myth, which as a society, we really need to work a lot, bring awareness that, with an assistive device, how much of work the child can do. So work meaning how much the child can actively participate, even if it is with some assistance from a caregiver or parent or therapist. But there, the therapist or the caregiver work reduces and the child has some active participation, ranging from 25%, 50%, whatever. More than that, we need to inform or we need to educate the parents about if the child is even minimally actively participating. You look at the confidence and the self-esteem of the child, which are so important in further social and emotional development of the child, right? Whether in any domain you are, all right? So it's not only about walking and talking, it is also about confidence, self-esteem, social emotional bonding in the home, everywhere else in the society. So this goes further and further, and developing self-esteem, confidence also have to begin right from the start. See, we cannot wait. We cannot have a step-to-step approach. One day my child will walk and then I will think about this. And this was the wake-up call for me when I started my practice in India 12 or 13 years ago. One mother whose child was already walking, although with AFO, some handheld assistance, whatever, she would open the door of my clinic all the time, or she would carry him up the stairs. When here I was doing stair training, and then I trained the mother, I said, let's see how the child, he can open the door, I'm sure. So, opening the door requires pulling and then stepping back, which is balance and some strength and, all these components. The wake-up call came when the mother said, and then there were many more instances like this. It was not only pulling a door, but I went through 2, 3 instances like this with the same mother over some 3, 4 sessions. So what she said is, no, ma'am, but I have to do everything for the child until he's fine. That broke my heart, and it was a wake-up call for me because I had just come from the USA, and then I started rephrasing, reframing my language, to a much simpler level and to meet the whole purpose of what we do therapy, why we do therapy, and at what point, how therapy looks different for all of us, for Puja, for me, for Sir, at different ages and stages of where the child is. But we have to meet where the child is right now, start from there, and everything happens for a broader purpose of active participation so that the child improves in all the domains and the child gains self-esteem and confidence. The child feels good about themselves. That is inclusion.
Yeah.
You don't want the child to be made felt, oh, poor me, I can't do this, poor me, I have to. Okay, if the child needs help, we have to also teach them to ask for help. Excuse me, please help me. I need help here. That is also fine. Absolutely fine. We all do that.
Right. Yeah. Yeah.
So that is
We,
inclusion.
yeah. We have a great question that actually goes with your answer. So I just want to read that out here. In today's therapy-oriented world where people with disabilities often face emotional and social challenges, how can therapists provide meaningful emotional support that truly understands their experiences and empowers them in their daily life? So I thought it kind of went, along with this theme that we are talking about, just having some kind of assistance, doesn't mean that, you are any less than anybody. And I think, um, so I say this to a lot of people I talk to. So if I'm repeating myself, apologies. But I feel like I don't see enough people, diverse people in society. Like when you're going out to a mall or a movie a theater or a trek or a picnic or whatever it is, you don't see enough as compared to the percent that is prevalent in the population. I feel like, our kids are not out enough. And when I say that, possibly I'm also looking at it as a motor therapist. Maybe there are children with, the sensory based sort of, labels that are out there. Um, and I don't maybe recognize them. But anyway, my point is I feel like we don't have enough representation in that broader sense for someone to develop this understanding how difficult a life could be. And I don't think it's a very difficult concept because irrespective of how typically developing you are, you always have some insecurities, you always have some fears about something. Whether they last for a short time or they are something that you carry, for many years to come, that's a different thing, is how you work on those, that kind of emotional regulation and development of yourself. But I feel like that doesn't connect. What I'm feeling is possibly what this person is feeling as well, irrespective of the label that they have, you know. Um, and so it's a very good question. I feel like it's only when I really jumped into the NICU full time that I started reading a lot more about supporting parent mental health, Initially, as an outpatient therapist, you kind of are supportive, but I didn't realize, the depth of how much support is required, to be very honest. So I don't have a good answer to this, Mr. Zoshi. If you have some experiences you would like to share, please unmute. We would love to hear from, you know, your experience as well.
Am I allowed to say something, Puja?
Yes,
Puja, let him answer, otherwise I'll speak. If he's answering, I'll wait for him to answer.
yeah. I also see he's written a little, but are you willing, sir, to just jump on the call? Okay, so I'll just read out the comment. Family plays a vital role in supporting a person with disabilities because they are the ones who understand their daily struggles, strength, and emotional needs most closely. When families and therapists work together, the support becomes stronger and more meaningful. Families provide real life insights, and therapists add professional guidance. This partnership creates, oh, sorry. Just missed that. Partnership creates a supportive circle around the person with disability through open communication, shared goals, and a mutual trust. Both the family and therapist can help the individual feel understood, empowered, and emotionally secure. Very, very well said. On that note, I want to say that we have a list of interviews and lived experiences, stories in the resource list that, we all thought kind of helped us, open up to this idea of providing that deeper support to the families. Go ahead, Asha.
When we are talking about emotional and social frame stuff, so I just want to bring out something. 29 years into practice, and to be very honest, I'll be very, very honest, and I think so. If you talk about neurodiverse kids, or let's take a kid with cerebral palsy or a kid with autism, whatever their labels are, I don't treat them with labels, but what I want to bring out is that these labels, when we all started practicing, it was called pediatric rehab, and we still call it. But all this has, the kids that we treat today have outgrown that pediatric rehab. Now, if you take cerebral palsy, to be very honest, it's completely outgrown. I mean, today you can talk everything, what we all discussed is great. But tell me, how many of us, when we practice, understand a lifespan approach? Like you brought out NICU. You do something in the NICU. Do you realize that impact can be seen through adolescence and adulthood? And that understanding is only not there for all of us. And now we wake up, now means woken up a lot, but that, oh my God, we need to do this and we need to do that. And if you really look at the unmet needs that are there available today for India, I only talk about India. I'm not getting the West because we live in India, and let's talk about India. Having said that, the unmet needs are huge. And if I go back retrospectively in my practice, one lesson that I want to share here, bringing that wish I had that knowledge, wish somebody guided me, that when a child is through the lifespan with me, and if I can pick up smart parents, they become advocates. That I've done. But I tell you, if we can send our parents early on, yes, we do counseling and we spend time with them, but getting help when the kid is at 2 or 3 years, sending them to a pediatric psychologist, psychiatrist has huge benefits, huge,
Yeah.
huge, huge benefits, and nobody talks about it. And I think so that dialogues or that stories have to come out a lot, at least in the Indian continent. And that's where I feel it's so very important. Thanks for allowing me to share my views.
Absolutely,
Yeah,
absolutely,
yeah,
Asha.
I'd like
that's very a valid point, and I totally agree with having, I feel like when we say multidisciplinary, we generally have PTOT speech, right? Like, and then there's a full stop. Like we forget the psychologist and the special educators as well. They are not somebody that will come later in life. They also have to go hand in hand with. So yeah, we are in one of the NICUs I am. We do have a psychologist, and she runs a parent support group. So that's just been a recent change that has happened there. But we can already see the change in how the parents are engaging with their infants in the NICU. So I completely, agree with that. We have a couple of uh, comments, which I'm just going to read out.
Pooja, if I may take 1 minute to add something.
Yes, please.
So this is a concept that I work with a lot. I'm not sure if this term called as co-regulation is popular among your PT, fraternity.
Yes,
Yes,
That's
it
absolutely.
is. It is.
As therapists, I think we all need to start working on co-regulation. If a child is scared, we need to teach the child how to express that, that I'm scared, the fear. If the child wants to hide behind the curtains to express that I'm scared, so be it. If the child wants to, hug the mother and say that I'm scared or I'm feeling anxious, that's also right. And these are certain strategies we also need to work on and teach. And that's where that self advocacy starts in the early stages, where we are addressing those emotions before they manifest in society as negative behaviors.
Absolutely. Um, I'm just going to, is it okay if I read some of these comments?
Yes, please.
Yeah, okay. So, Sunita is asking about this mother who has a child with ASD, and she's going to different cubicles, looking for help from different therapists, and everyone has a different, what to do for this child, a list of things. And so she's very confused, and she would like for us to just talk a little bit about how, we can help this frustrated mother. I think, sir, this is your forte. Ashish, sir, you want to?
Yeah, yeah. I think, the parents need to be given an idea that,
Oops.
talk to the child or play with your child. So, different professional approach, I think, at some point we need to come to a conclusion that one needs to give one program, and that needs to be goal based and context based. So the families, we work with the families, but at the same time we also need to think that families also are under tremendous pressure or mental pressure, because one doctor has told them your child will never walk. So that kind of approach, I think we need to have our medical fraternity with us along with other professionals, so that it's a kind of right from your NICU, till say, so for example, 11 years, 12 years, we need to have a kind of education system where we will come to know how to deal with ever evolving or ever challenging condition like cerebral palsy or ASD. So it's a kind of, you can, Pooja, you can continue.
Yeah, I want to add here, please, if I'm allowed to.
Yes.
Yeah.
I think so to this mother, the biggest mindset shift is not the mother. I think so we as PT, OT, speech, all therapists need to first have a mindset change. And I think so every therapist needs to understand that you cannot call a child every day and go through 100 cubicles or whatever it is. I think so the biggest shift that I feel on this podium as the ICP, I would say that mother is the biggest therapist, or a caregiver is the biggest therapist. And I think so if the child comes to me or goes to XYZ, it is my responsibility to empower a parent and give home programs. I think so in today's world, the word home program is completely forgotten. And home program in terms of fun, okay, and family is what they need to do. And that just, it's like, come do an exercise, go, but why you do what you do. I think so. This is something that needs to be taught to every young therapist, that a mother is the nucleus and the primary therapist. Thanks for allowing me to butt in always, Pooja.
Oh, no problem. We do want, like, again, it was a conversation. It was, um,
May I add one more
Yeah.
line? Like,
yes.
I always believe that, intervention strategies must be tailored with resonating ideas stemming from cross-disciplinary ventures. We need to come to a point that, when you bathe your child, you can also teach your child body parts, or you can also teach your child, the smell of the soap, or what do you call soap, or, a mug or a bucket. So giving, this special education, quote unquote, the word special education, it is being automatically performed or executed when a child is being bathed. If you tell your child that, you raise your arms and I'm going to put on your shirt, the child is hearing at least 10 words. So the vocabulary develops. So if we all the therapists come to a point that, how things can be taught, is ultimately it's learning. Everything is, boils down to learning. So learning will take place through motor activities, or through physiotherapy, through occupational therapy, whatever name you can give these interventions are. But I think, that is the crux of the matter, is the how the child will learn.
Right. Um, Ushma, you wanted to say something, or can I move to the
Yeah,
next one?
yeah.
It's 9
Yes.
o'clock.
Yeah, yes. The last point I'll make is continuing with what Asha said, is that home program is again a very misunderstood thing. It should never be a list of things or a list of exercises. Oh, I will do 10 times this or 5 times this or that. The home program should be, it has to be a part of your daily routine, the daily, life in the family. And obviously, the fun factor, the enjoyable factor has to be there. It has to teach some function to the child and to the family or the mother, as a part. So that is one thing about home program, because even in this day and time, parents ask me, just tell us what to do or give us a list and we will do it. But it has to be a part of the daily family routine. And there comes, sir, when he said, oh, when you're bathing the child, you teach the vocabulary, you also teach the child, all these motor skills, right? Right, filling the mug and putting it on your body or something like that. It has to be holistic. So there comes the routine, the daily routine that every family goes through in a day, including us. So first we have to focus on those tasks that a daily family in the daily routine go through, focus on those tasks, and then see how we can help the mother help their child in developing these, abilities.
Yeah, so I just wanted to
Mm.
say I kind of agree with all of this, but I
Mhm.
also want to say that I feel like the pressure on the mothers is so much, the burden on the mother is so much that she forgets to be a mother. She forgets to just, you know, experience that pleasure of being a mother, right? Because there's
Yes.
already so much worry about what's going to happen with this child, if they're already in that severe delay category, the fours and
Mhm.
fives, GMFCS, they can see where this life is going, right? And so they're extremely worried for every small thing that this child is going to face in the future. They are running, door to door to get some answers, to like hang on to that hope. And I feel like in all of this, right, where is that safe space for this family to just be a family? And like, no matter what, there is a biological like bond attachment, that needs to be nurtured. Even though it is there biologically, it's not going to magically like appear, right? It needs to be nurtured. And again, I see that a lot in the NICU, where, when the mother is anxious to touch the child, where, she's struggling to like just put that worry aside and say, oh, look, my baby looked at me, when I walked in and I said hello, they kind of opened their eyes and, reacted to my voice. Some of those things just kind of get pushed, to the wayside because you only have certain number of hours in the day. You have to cook, you have to clean, you have to do the laundry, you have to get, you know what I mean? Like you have a life. And I agree that, routine based, they are very key factors. But I also feel like, that's where we need to, like, what can I do that the mother can't do? Right? So there needs to be you know, some role burden sharing in that sense. So anyway, let's move forward
Yeah,
because it's 9 o'clock and I do
yeah,
want to address some of these questions that
yeah.
have come up. Someone has a great suggestion to address grief in families. They're talking about parent-mediated approach or a peer-to-peer interactive series for parents where they benefit from each other's support, which is great. Totally agree. Um, it is not a silly question at all. Someone is asking to be friends with them. So I'm assuming that, they mean people with disabilities. How do you become friends with them? And I don't think it's a silly question. I absolutely find myself in that, dilemma sometimes as well, because most of the time you're there as a therapist, right? And then you kind of, if you meet them outside, suddenly you're like, oh, what do I say to this person? Because you're so focused on being the therapist that you're right. It is a different or a difficult skill in that sense to have. But I don't know, I think you just, you be cool. I don't think you need to stress so much, you just need to chill. That's another human being. You know,
No, no. So here, if can I add
yeah.
here being a friend, meaning I do it all the time, meaning it's not just outside of your therapy setting. When you meet them, because that happens rarely, you be a friend with them during your session.
Mm.
Like, okay, let's do this together, whatever it is, putting a puzzle piece or picking up something, or let's do this together. Rather than even saying, let me help you, I have, over the years adopted this. So we can do it together, you know, you know. So that is one way of being friends out of the many.
One thing I forgot to put on that list of resources, um, there is a lovely therapist here in Pune called Supriya. She actually
Adda,
was
she does. She does that. I'll send you that. She's on
I
Instagram.
know, I
Yeah,
know. Yeah,
lovely.
I know. So she, yeah, worked with me, when we were starting off many, many years ago. But recently she's actually, well, too long a story, but anyway, she started a group called Social Adda. It is on Instagram. I would urge everyone to please like the page, so that we give her all the love and support that she really deserves. But it started off with, like Asha said, some of the kids that we worked with when we started off are now adults. And we used to meet at someone's wedding or, have these once a year or once in 2 years kind of a social gathering from the, like our ex-clinic families. And she kind of, picked this up and said, the kids need a space of their own. They need to participate in society because they are kind of homebound now because they are adults and have nowhere to go. So she started this thing called Social Adda. And I'm very happy to say that my son's school kids also volunteer there. And she's doing a fantastic job with it. They do once a month, they go do some social activity. They just went horse riding, last month.
They had
And
this Garba
so
also,
there
right?
are, sorry?
She had the Garba and she had many things. She had many.
Yep,
Yeah.
yep, yep, yep.
Yeah, I've sent you
So
the link. If you can just share it in the group, I've just sent it on WhatsApp. You can share the Instagram link for the class if you can.
I
No, no, 1 minute.
will
I'll do it.
I will write the name because I don't
I
this is
will
all.
share it. I will share it. I can share it. Don't worry. I thought
Yeah.
you wanted to do that. I'll do that.
Um so yeah, I feel like, therapists are attempting to build that connection with their clients, in those kind of social situations as well. And I think that this will definitely also like the earlier question was, how do you kind of emotionally empower them, make them feel like, they're part of the larger group of us. I think a lot of these things, if they propagate further, would be a great way to move ahead. My last question was going to be about advocacy. What can we do as therapists? But we are running out of time, and I don't want to, pull this on for because it would take us another half an hour to get through that conversation. Um, so Asha,